Hello, everyone, again, and welcome to this webinar focused on understanding your kidney lab results. Please note that live closed captioning is available by clicking that CC button at the bottom of your screen. We will be recording this session so that we can share it later on our website for other people to learn from as well. That's www.alportsyndrome.org. On our YouTube page, we'll share it there. My name is Lisa Bonebrake. I'm an Alport patient. I'm the proud parent of two young men, one who received my X-linked Alport syndrome gene mutation, the other did not. I'm also the executive director of Alport Syndrome Foundation, and I will be your moderator today for this session. I'm honored to introduce our featured expert, Dr. Anjay Rastogi. Dr. Rastogi is professor and clinical chief of nephrology at the David Geffen School of Medicine at UCLA. He's board certified in nephrology and has a Ph.D. also in pharmacology. Dr. Rastogi founded the Core Kidney Program at UCLA. He also serves on our Alport Syndrome Foundation's Medical Advisory Committee. After a brief overview of critical kidney lab values using some slides, Dr. Rastogi will get right to your questions. Many of you sent questions in advance. Thank you so much. We will get to those. But for now, please sit back and listen because Dr. Rastogi may answer some of those questions that you're interested in knowing through the context that he's going to be providing for a few minutes. And then once we get to Dr. Rastogi's slides and context, I'll monitor the Q&A function and make sure we get to your additional questions. So Dr. Rastogi, thank you so much for joining us, and I'll turn things over to you. Thank you so much for making time to share your expertise with us today.
Thank you so much, Lisa. And I just wanted to say that it's been such an amazing experience working with you and the Alport Foundation. So I feel very fortunate that I'm here today speaking to the patients. So, and the topic today that you picked is very important. You mentioned in my background that I'm a nephrologist and also I'm a pharmacologist. So we did, there are a few things that are very important for patients to become their own best advocates. And one of them to understand your medication. So if they haven't seen the webinar that I did on drugs and medications, what you should know, it's very, very important. So please do that. But today what you asked me to do was speak on labs and how to read them. So that's the second half of being your own advocate, because you need to understand the labs, you need to follow them, you need to question. And now in electronic healthcare, world, your labs can be posted. At UCLA, we have the My UCLA chart. If you're signed up, your labs will show up automatically, and you don't even have to ask that. So I think this is about being proactive. I think this is a very important program that you put together, and hopefully I'll be able to share what I think a patient should know. And if there are questions that we don't have answers to, we will get back. I'll put my contact information there as well. So let me share my screen now, and over here, and this is going to be the PowerPoint. 1 second. Can you see this, Lisa? Can you see the slides? Okay. Very good.
Thank you.
Very good. Thank you. So topic today, and I want to give a bit of the context of the labs that we'll be discussing. And for some people, especially the people who have been to my previous presentations, this you might already know this, but it's always good to have a recap. And for people who haven't seen these presentations before, it's good to know what those labs really mean. So you can put those labs in context. This is just a disclaimer that all the information that we share here is only for information. This is also our contact, Core Kidney at MedNet. If you have any questions beyond this, you can send them to Lisa. Lisa can send them to me, or you can send them to me directly. And I will make sure that I copy Lisa when I respond on that. So the whole idea is that we share this information with everybody. A question that you might be asking might be relevant to other people as well. So it's always good to share that piece of information. This is our website. If you haven't visited, please do so. We actually have quite a big Alport program, and this is what CORE really stands for. And one of the big things is outreach and education. So those are the O and the E in our mission, just like what Alport Syndrome Foundation has as well. And this is a green ribbon campaign. I think I'm wearing one too. If you want one, we can send them. Pink ribbon stands for breast cancer. All of us know about that. Green ribbon stands for kidney disease. And this campaign was actually started at UCLA several years ago by our circle of core members. So the topic today is kidney labs, but before that, we need to figure out what the kidneys do, and this will be relevant. So just to give you a broad perspective, when you say kidney test, renal, and the other word sometimes we'll be hearing is renal, even though we are trying to move away from renal and use it, they mean the same thing, identical. But we try to use kidney more than renal. But you can see a kidney panel, renal panel. The question comes up, what are the basic tests that we do to assess that your kidneys are not damaged or working properly? So the four big categories is you check the blood. We'll be going on the blood test. You check the urine, because kidneys actually process the blood and form urine. The third thing is you do an imaging test. It could be an ultrasound, it could be a CT scan, MRIs, whatever it is. And the fourth one is you do a biopsy. If there's you put a needle in, take a small portion and look at it under the microscope and do staining and all that stuff. So those are the four big, and we'll be going over this over and over again. But where does this fit in the bigger picture? So these are your two kidneys, and as you know, it's in the back. It's under the 9th, 10th, and 11th ribs. So they are normally protected by your rib cage. And the longest dimension in general, if you look over here, is about 11 centimeters, 9 to 11 centimeters. But keep in mind, in your fetus, the kidneys sit in your pelvis, and then they gradually ascend. And come. So why is that important? So if you look at kidney function testing, you can find out that when you do an image, the kidneys might not be up here. They might be here. And what does that lead to? It might lead to kinking of this ureter or obstruction. So these are all important things when you're looking at assessing kidney function. And I'll be going over that, the connection with Alport, so that's something just important. But just keep in mind, because if you have Alport disease, doesn't mean that you can't have other kidney diseases. And I think that's also very important, perspective to keep to make sure that you don't get blindsided that I have Alport in it. And we have sometimes that things are superimposed on a base of Alport. So the kidneys are here at the top. They ascend from the pelvis, and then they filter your blood, and the filtrate finally forms urine. It goes through these tubes called the ureters. And then the urine is stored in the bladder till the person urinates. Sometimes they become incontinent, so they might have accidents, but normally the bladder, and there's a significant capacity of bladder that it has, and beyond that, the urine will start getting backed up in the kidneys, and you don't want that. That can cause extra kidney damage as well. But let's look at one of the common things. And like I said, I'm incorporating a lot of questions that were asked as we go along. One of the things that we do when we test for urine, we do two main things. One is to test if there's any cells in your urine, red blood cells, white blood cells. And the second is to check protein. And we'll be going over that separately. But when you see blood in your urine, a term that we medically call hematuria. And let me see, I'll put that in the chat box somewhere that, let me see 1 second and see if I can put that in the chat, because I think this is an important term to know. You will see this in your head that this patient has hematuria. So that's what hematuria is. And let me go back over here. So, okay, great. Oops, where did that go? Here, hematuria. So what does hematuria mean? Hematuria means basically there's blood in your urine. Now, there are two terms that we use for hematuria or blood. One is called microscopic hematuria, and the one is called gross hematuria. And what is the difference? The gross hematuria means is that you're basically peeing blood. You can see it in the toilet, or as it's coming out, it's red in color. So that's called gross hematuria. But in Alport disease, it's mostly microscopic hematuria. And what that really means is that you can't see blood by the naked eyes. But when you see it under the microscope, you can see red blood cells. So that's what we call microscopic hematuria. And that's really one of the cardinal features, key features that we see. So if a patient comes to me and I see red blood cells in the urine under the microscope, one of the biggest things in the differential diagnosis for that hematuria is Alport disease. So Alport. So that's something that we now keep in mind that blood is coming from your kidneys, right? It's actually coming from your blood and the glomerulus, and we'll be going over that in a bit more detail. But the blood can come from anywhere from here to here, right? So it could be coming from your ureters, it could be coming from your bladder, it could be coming from your prostate, it could be coming from urethra. Why am I mentioning all this stuff? So when you have blood in your urine, you have to make sure that all these aspects are looked at. You can have a kidney stone that's causing hematuria. You can have an infection there. You could have, patient can have cancer that's causing blood in the urine. So when you look at blood, it's not just coming from the kidneys. It actually can be coming from anywhere from the kidneys to where it comes out in the urethra. So that is what we call hematuria. That's what we call blood in the urine. And that's a differential diagnosis for that. Now, what does a kidney look like? So the other thing is the imaging. So one of the things that we look at in the kidneys is the size. And there's some diseases that the kidneys actually get enlarged, and the classic example is the other inherited monogenic cause of kidney disease, actually much more common than Alport syndrome, called ADPKD, autosomal dominant polycystic kidney disease. And in this, the kidneys get larger. They can get humongous. So in that, what we look at the kidney size. And normally when we look at kidney size, we are looking at the longest dimension. But now we have gone further, more advanced and for a few steps ahead, and we look at the three-dimensional size of the kidneys, a term that we use called TKV, total kidney volume. And let me see if I can put that over here, TKV, which stands for total kidney volume. Now, in patients with Alport syndrome, it's different. The kidneys don't get bigger. They get actually smaller. And that's one thing that we do when we do an imaging test, ultrasound, CT scan, MRIs. You can see that this is a disease, and this is the norm in most of the chronic kidney diseases, that the kidneys get smaller, they get shrunken, and the surface, which is smooth, is now more granular. So when I see this on an imaging test, what that implies to me that this is a chronic condition. The kidneys have been diseased for some time, but this does not happen overnight. The inflammation, fibrosis, scarring is not. It takes time for that to happen. So that is something that we look at. So the other big test, like I said, the big four buckets, right? The blood test, the urine test, imaging, and a biopsy if needed. So in the imaging test, this is one thing that we look for. We also look for if there's any obstruction, there's backup of urine. So those are things that you should be looking at when you're the other point. If there's any mass in the kidneys that could be looking cancerous, renal cell carcinoma is not an uncommon disorder, and that can also lead to blood in your urine. So we look at that as well. Kidney stones. So these are all things that we glean this information from the imaging tests. So progressive kidney problems. Now, this is your nephron. The term that you probably have heard, that your kidney specialist is also called a nephrologist. And where does that term nephrologist come from? It comes from this. This is the nephron. This is the structural and functional unit of your kidneys. And each kidney is made of 1 million of these nephrons. But let me walk you through this, because this is a very complex organ. Kidneys are the most vascular organ in your body. 25% of what your heart pumps goes to the kidneys. Makes sense, because the purpose of the kidneys is to purify the blood. Now, having said that, the other implication of that is when you have cardiovascular disease, you have kidney disease, and vice versa. So one of the things, the take-home message for the audience today is that if you have Alport syndrome, if you have this disease, kidney disease is happening, and then the vascular system will get involved eventually. So it's better to be proactive and to prevent the kidney disease from happening in the first place. But let's go over this. This is the red vessel or pipe is called your arteriole. It's the artery. And the blue one is the efferent arteriole, and this is what drains the blood. So the afferent arteriole, this pumps blood into this cup-shaped structure, and then the blood comes out. the kidneys work as an ultrafilter. They work as a sieve. And the purpose of the sieve is to purify the blood, getting rid of all the waste products, but at the same time, retaining the good products in the blood, right? That's what a filter is. That's what a sieve is. So this is your glomerulus. And let me put that term here too, because this is an important term for everybody to know. This is the structural unit of the kidneys that actually purify your blood. And then what comes down from this is the ultrafiltrate. And this ultrafiltrate goes through different segments of the nephron, the proximal tubule, the loop of Henle, the distal tubule, collecting duct, and eventually comes out as urine and goes into the ureters. So you saw the pipes, those are called the ureters. So, and it's processed. This urine is processed by different segments of the nephron. So let me get back to the glomerulus. So ideally, it will retain all the good products and get rid of the waste products. But it's not an ideal filter, you know. And there are things that sometimes get filtered that the body needs, a lot of electrolytes body needs, and sometimes proteins. So what these different segments of the nephron do is they actually they modify that ultrafiltrate. They reabsorb and secrete substances as needed. Drugs get secreted by this way as well. Now, the other thing that happens is a small amount of protein is a big structure. So the bigger the structure, the lesser chances of it being spilled into the urine. So that's dependent upon the size, among other things, of the substance. For example, if a substance like glucose, which is a small molecule, it will get freely filtered. And most of it is reabsorbed, by the way. But as a protein molecule tends to be a bigger molecule, especially albumin. There are different kinds of protein, and albumin is one kind of protein. So an albumin is bigger protein, so it tends to retain. So there's a small amount of lower molecular weight proteins that get filtered, and once again, most of them are reabsorbed as well. But albumin, which is a type of protein, is a bigger protein, and it should not be ending up in your urine. So what do? We test the urine for protein, and more specifically, we test it for albumin. So just keep in mind, the albumin is a type of protein, and that's the one that is more sensitive to kidney damage, and we follow that. But some people ask, what is the difference between protein and creatinine? So the protein and albumin, and the key thing to keep in mind is albumin is a kind of protein. Now, when normally we should not see any significant amount of albumin in the urine, but if we see that, what that means to me is that this glomerulus is damaged. And that's why the protein and the other important thing is the protein that is filtering is also actually damages the tubule, the nephron, the different portions. So it's a double whammy. Number one, it indicates, so protein or albumin in the urine indicates that you actually have damage to the glomerulus, but also at the same time, it actually can damage further your nephron. So keep setting up. So we as nephrologists monitor that very closely. And it's also a test that we follow to see if the therapy is working. So if you're spilling a lot of protein and the protein levels are not coming down, then we have to ask the question, is the therapy actually effective? And it's one of the key endpoints that we look for in our clinical trials. So that's with the protein and the albumin. What other things does the glomerulus try to retain in the blood? Well, your blood cells. Blood cells are important. You don't want to lose your blood cells, and they are big structures. They are well, bigger in the sense that they won't pass through the filter. Red blood cells is one of those cells. So if you see red blood cells in your urine, and you think it's coming from the kidneys, and there are ways to ascertain which part of is it coming from the kidneys, is it coming from the ureters, bladder, you know, those stepwise approach I mentioned. There are ways which are suggestive that the blood is coming from the kidney, and specifically from the glomerulus. So if you see red blood cells in the urine, you would really want to see if the glomerulus is damaged, because that's allowing these red blood cells to actually filter through when they should not be filtering through. So that's where the hematuria comes in. We spoke about proteinuria, but let me talk about another key lab. We talk about GFR, glomerular filtration rate. We talk about creatinine. You also will be hearing about something called Statin C. And let me put that too. So a couple of things over here. So creatinine, not creatine. So creatinine comes from creatine. There's something called urea. Also, sometimes call it BUN, blood urea nitrogen. BUN. And there's some more. Oh, is this only going to the host and panelists? Lisa, can you make sure that everything that I'm typing is shared with the audience? I think it's only going to us.
I absolutely will, Dr. Rastogi. And you're starting to get into some of the questions that I see the patients have written to us in advance about BUN and creatinine. So we look forward to hearing about that. And then we also want to make sure we have lots of time to get into the other questions that patients have. Yeah. But I will make sure I share these with everyone.
Very good. Thank you so much, Lisa. Very much appreciate that. All right. So let's talk about the term GFR, which is actually very, very important. And I'll spell that out. This is the single most important test that we look for in your kidney function. Glomerular. I'm not the best typer. I have to apologize. Glomerular filtration rate. So what is the glomerular filtration rate? It is the filtration rate of the glomerulus, this cup-shaped structure. And in your labs, and I'll be going over that, there is something that we call, how is it calculated? There are different ways of doing this. You can do a 24 urine collection, which some of you might have done, or you could use equations. And what do we put that in equation? A thing called creatinine. So we'll be going over that as well. And these are called estimated GFR. So those are the ways. So GFR is something that you should follow in as a trend to assess your kidney function. So now, what do the kidneys do? These are all the stuff that kidneys do. And we'll be going over. There are two types of kidney injury, acute and chronic. And we'll be focusing on chronic because Alport syndrome causes chronic kidney disease, but you can have superimposed acute disease on top of this as well. And we have the different kinds of tests that we do and much more exhaustive testing that we do for acute, the complement levels and antibodies and stuff like that. So we are not going to go, we're going to go into what an Alport patient should know basically about testing of kidney function. This is how NKF defines chronic kidney disease and what do your kidneys do? They purify the blood. They involve in fluid, electrolyte, and acid-base maintenance. Now, having said that, why am I mentioning this? And a lot of people had asked about what other tests do you do, right? And after you've done your GFR and kidney disease, if they're abnormal, then we check the potassium, we check the calcium, we check the magnesium, then we check the phosphorus, we check the acid-base bicarbonate, and further down, we will look at bone function. We'll check the PTH, vitamin D, phosphorus, and then these patients also tend to get anemic. Why? Because kidneys produce a hormone called erythropoietin, and also in kidney patients with advanced kidney disease, the iron absorption is impaired. So we check iron levels too, and we'll be going over that in a bit more detail. Now, and blood pressure maintenance is also. And when your kidneys don't work well, these are things that happen. You get anemic, so you also check the anemia labs. You check bone and mineral disease. You check the acid and electrolyte labs as well. And then finally, cardiovascular disease. Those are the key things that we look at in hypertension. But let's go back to how can you assess kidney function. So we spoke about that. And Lisa, what was the first question about the basic metabolic panel? If you can put that in the chat or Q&A so everybody can see and then
sure. And we have our closed captioning on as well, so everyone's able to read and see all the words
wonderful.
And all of our text. One question was, what is the difference between a renal or a kidney panel and a regular panel?
Okay, very good, very good. So I'll answer that as well. Blood test, including creatinine, and we said creatinine is used to calculate GFR, and the urine test and imaging test and biopsy. So let's talk about what we call as panel testing, right? Panel means that you check more than one lab. And let me see if I can get that one lab over here. This is causes, further. Okay, here we go. Can everybody see this? Lisa, can you see this?
I can see this on your screen. And this looks like a basic lab results. Is that correct?
Yes. So this is, as you can see, it's blood right over here. It's chemistry. So we'll be going over this. And these are all the things that we normally test for routinely in some of our patients. So let me go, and this is, and the other thing that I did over here is look at the trends. One of the things that I would really like everybody to do is start looking at trends. So you trend them out. One value will give you some information, but what you need to look at is the trends, from May 5th, May 19th, June 30th, and it go on and so forth. So that's number one. When we order blood, I can order potassium, only potassium. I'm worried about potassium, we check potassium. I can only order creatinine, but that's the only thing that I want to know. So it limits the amount of blood you're taking normally, and we're not doing unnecessary tests. But there is something called a basic metabolic panel. So it's a panel. It's a group of tests that we are doing. Just 1 second, I apologize. Somebody just paged me. So it's a basic metabolic panel. And what is a basic metabolic panel? It includes sodium, the basic electrolytes and creatinine that we know. So that includes sodium, potassium, chloride. This is the acid load. I'll be going over that. Urea, nitrogen, and creatinine. This is what we call the basic metabolic panel, and glucose is also added over there as well. Then there's something called a comprehensive, so a CMP, comprehensive metabolic panel. So now we are doing a much wider net over here, right? So starting from just one test, like checking potassium, then we do a basic metabolic panel, a BMP, and then we do a more comprehensive metabolic panel. And those normally include, calcium, phosphorus, magnesium, and also your liver function tests, the LFTs. So that's included in that as well. And albumin, and so this is, and keep in mind, when you look at albumin, don't get confused. There's albumin in the blood, and there's then albumin in the urine, right? And the albumin in the urine is coming from the blood because the glomerulus is damaged. So this is what we call a basic metabolic panel, comprehensive metabolic panel. And then you can see this is the lipid panel. So it's a panel. It's more than one test. And when you order a lipid panel, you get cholesterol, you get HDL, which is high density lipoprotein, low density, non-HDL, and triglycerides. So these are the different panels that we are looking at. Now,
I'm so sorry, Dr. Rastogi. I think one important question that I hear a lot, and that was asked quite a bit that came in from patients, is I think we understand that we hear a lot estimated, glomerular function rate, like EGFR. We hear this all the time that our nephrologists are interested in knowing. And I think, that value comes from looking at this panel and those results and how that's estimated. And a lot of patients had written in and asked, well, how much do we need to worry about that? And mine seems to fluctuate. How much weight should we put on that, and how much concern about our EGFR? Is that something that you can address?
Yes, absolutely. That's a great question, actually, Lisa. And I was coming to that actually, because the creatinine is a blood test that we do. It's a simple test, widely available, very inexpensive. And we use this to calculate the GFR. So the equations that are put in, whether it be the CKD EPI, whether it be the MDRD, Cockcroft, whatever it is. So we use those equations we put those in, and you can do it yourself too, by the way. You can go to, the lab does it for you automatically now, but 10 or 15 years ago when this was not, I would literally, manually put those numbers in and calculate. So this creatinine is used to calculate GFR. And as you can see, there's a difference between being African-American versus non-African-American. And this difference is probably going to go away pretty soon. So we'll be reporting just one and GFR. So you look at the creatinine and you calculate the GFR. Keep in mind, this is an estimate. And that's why the trends are important. That's why, Lisa, you mentioned about fluctuation. There are a lot of things that can cause fluctuation in your creatinine, which is the basis for your GFR. What can cause changes in creatinine? Well, the very fact that if you're a bit dehydrated, that can cause your creatinine to go up. If you had, where does creatinine come from? From creatine. And where's creatine? It's in the muscles, right? So if you had a steak or if you had meat, especially cooked meat, which converts creatine to creatinine, you can see a bump in your creatinine just based on that, and that can alter your GFR. So there's a lot of things that go into this, and there are a lot of limitations. Now it's an inexpensive, widely available test, but has limitations. And that's why there's something called Statin C that you probably will be hearing a lot more down the line, which might be a bit more accurate than what we have right now. But the short answer is that the GFR is calculated. The concern would be that, and keep in mind, this is a derived number. It's derived from creatinine. If the creatinine goes up, GFR goes down and vice versa, because it's being derived. So if you see a big bump, in your creatinine or drop in GFR, for example, here 1.49 to goes to 1.32, or actually the other way around, 1.32 goes to 1.39 or 1.49 for that matter, that's a big increase in creatinine and a significant drop in GFR. So your blood should be retested. So it's not just, and if it stays high, then your nephrologist or your doctor will look at why do you think it has gone up, and they might add further tests to evaluate. So I hope that answers your question, Lisa.
It does. Thank you very, very much. I appreciate that. It's a question. I mean, we hear that all the time from our nephrologists as patients, that they're concerned about our GFR. They want to know what our GFR is. And so, we need to understand what that means and how much what is the importance of it. And I think that is really important for us to understand, that it's important for us to look at it over time and see what that trend is. A lot of us struggle with potassium, right?
Yes.
I hear that a lot from patients. We hear it more and more. And also the standard of care that we're on, ACEs and ARBs, can often sort of exacerbate that. Mm-hmm. Somebody asked, a patient asked, can you review normal potassium and normal phosphorus ranges, and what steps can be taken if either are high or out of range?
Right, very good. So potassium and phosphorus, let's separate them, because the two, there is some correlation with kidney disease, but let's focus on potassium first, because I think that's important. So always go by your lab's normal range. Every lab has a bit of different calibration. Our lab could be 3.5 to 5.5. Your lab could be 3.6 to 5.1. So that's the first thing that you have to look at. And that would be listed, because most of the time, as you can see, there's a red arrow. What that means is that the creatinine is higher than the normal lab for that. But sometimes, and this is not a very good example, because the GFR is probably more important than the creatinine values, and that's why we report that. But first, look at potassium. Is it high or low? Now, even though we tend to focus a lot more on high potassium, because that's what happens, but you can also have a low potassium, and that can cause a lot of problems too. And some of the common causes, or the most common cause of a low potassium, is on being a diuretic, right? That causes potassium loss. So make sure that your potassium is within normal range, first of all. And then if it's low, then the first thing is to find out why is it low, right? And address the cause. So, I always say, if a patient comes to me and I see an abnormal range and I give them a medication, but not address the cause. So there are two things, cause and the management. And the management a lot of times depends upon the cause. So if a patient's coming with a low potassium and I give them potassium back, I really have not done justice to them. Because if it's a diuretic that's causing it, right, then the question that comes up, can we adjust that diuretic? And if it's not, then you give them more potassium-rich foods, and then you give potassium supplements. So that is a way to deal with a low potassium. And then the high potassium, same thing. Look at the cause, look at the diet. And then, if they need to be on diuretic, they can be on diuretic. That will also cause. And then potassium binders, depending upon what it is. So that is the way we escalate the care. But looking at the cause is very important.
I think that makes sense. A lot of patients that we speak to on a regular basis at the Alport Foundation tell us that they struggle with high potassium.
Yes.
I know that renal diet can play a role, but not always is effective enough for patients
Yes.
to make a big enough difference. Why should patients be concerned about their high potassium? Can you just briefly mention that? I'm not sure that all patients understand. I think it's an important point.
Yeah, I think that's a very important thing, Lisa, because there are a few things that keep us at night, and one of them is a potassium. And why is that? Because potassium actually affects your heart rhythm. And high potassium, as well as very low potassium, can really put your heart into big trouble in the electrical activity, and including a cardiac arrest. So potassium is something that we don't take lightly. It's a very, very important thing. And the other important thing about a high potassium, or even a low potassium, is that it does not cause any symptoms most of the time. And that's why it's part of the lethal cocktail. When we inject these cocktails into somebody that we want to put them to sleep, or it's a death sentence for them, we give potassium because it's painless, which is not good, because if you had symptoms. So the short answer is you really have to be very cautious about your potassium. It's the first thing that I would look at when I get a broad panel testing.
Thank you so much. I really appreciate that. I think it's important for us as kidney patients to understand that importance, and pay attention to our lab results and work with our doctors proactively. Another important thing that I think the word comes up a lot, but not always everybody understands the association or the meaning. At what stage of kidney disease do I have to start monitoring my hemoglobin count? That's what one of the patients asked. And I will quickly say to all the folks who are listening, again, thank you for joining us. If you have questions, please start to put them in the Q&A function, and I will start sending those to asking Dr. Rastogi. I'm still working down some questions that we received in advance, but please feel free to use that Q&A function. So hemoglobin count, why should I pay attention to that, Dr. Rastogi?
Yeah, so let's start. That's a great question. And I just want to go back to this slide. This slide is based on your GFR, and based on your GFR, you fall in different stages. Stage 1 is the most advanced, the early stage. Excuse me. Stage 5 is the most advanced kidney failure. You need dialysis or transplant. At what point? And then when you have chronic disease, the kidney compensates for all the stuff that's going on in your body, right? And the question comes up about anemia and iron deficiency in a patient with kidney disease. So most of the time, first of all, you can see anemia because of kidney disease at any stage, even as early as stage 1. but definitely by the stage 4 and 5, the erythropoietin production of the kidneys gets limited, and iron absorption becomes limited. So iron is a key element for red blood cell production, hemoglobin. And then you also have deficiency of erythropoietin. So you have two things actually causing, and that will lead to anemia. So for any patients with GFR below 30, for sure, but even in stage 3 and stage 2, we should be worried about anemia of CKD. And those are the labs that we look at. Now, since we brought this up, let me bring up one of the slides. This is what we call the hematology slide, as opposed to the chemistry slide, and we are still looking at blood. So what are some of the key labs? They look at a whole bunch of labs that come here, but what do I tune into right away? The thing that I look into is hemoglobin. That's what we look at. Hematocrit is calculated from hemoglobin. So that's number one. So his hemoglobin, this person is, these are real labs, by the way. This is one of our patient advocates and ambassadors. And we have obviously de-identified him, but he had shared this in our public meetings and all the media releases there. But his hemoglobin actually was very high. And this is a transplant patient, by the way. So 17.5. And your normal range is anywhere between 15.5 to 13.5. So we look at hemoglobin, but in kidney patient, this is low, not high. So we look at this. The other thing that I drop down to quite quickly is this. We look at the iron panel. And here, what I really look at is the iron saturation as well. And we really want it to be above 20%. So when do we start worrying? Well, if you're going to a blood test, an annual blood test, you should get a CBC. It's a pretty simple test to do. So you don't, and you will get these results, right away. But it's definitely if your GFR is below 30 and even below 60, then you should start monitoring these labs, more frequently and addressing them upfront with your nephrologist.
Thank you. That's really important. Thank you, Dr. Rastogi. I do want to quickly note there is a patient from Pakistan that has asked us some questions for Dr. Rastogi. And
Yep.
Please note, because they are directed really specifically toward a young patient, our guest, I want to let you know that I will be following up with you offline
Yep.
and following up with Dr. Rastogi about your personal questions about a personal patient.
Absolutely.
Thank you so much. One question that came up after we talked about imaging, which I think is really important, and personally that was new to me very recently in my own experience. How often should adults have imaging done to assess kidney size? You had mentioned the size and the total kidney volume. Can you let us know? And it's maybe not just adults as well, but I know you're an adult nephrologist, but how often in general, once you've been diagnosed with Alport syndrome, how often should we be thinking about making sure that our imaging is done?
Very good question. So first is what I do for my patients. I always get a baseline and get an ultrasound. You don't have to go to the CT scan or MRI. CT scans have a lot of radiation. MRIs could be very expensive, and insurance might not even approve it. So a simple ultrasound, which is inexpensive, widely available, has limitations in reproducibility. That's what I would get, Lisa, first of all. Now, for a patient with Alport syndrome or chronic kidney disease, after that, we only get imaging tests if indicated. For example, if there's fresh blood in the urine and we are concerned about a stone, if there is, cancer might, something has changed. If all of a sudden they were stable and things got out of control, then we order. So, but it's not routinely indicated after that. It's only if there is an indication based on change of their kidney function, which is more abrupt change, not the gradual decline. Now, in a condition like PKD, polycystic, especially autosomal dominant polycystic kidney disease, we actually use the kidney size, the total, as an indicator of kidney function, which is not the case in Alport. So what I would say, a lot of people don't even get baseline ultrasound. I do. I think there is an indication. You should always have a baseline and keep that report with you. And after that, as far as the guidelines are concerned right now, there is no need to have a follow-up unless there is an indication of change in kidney function or something else is going on.
And with that, in Alport syndrome, then, if there's so you're trending where your creatinine is rising, you have indication of potential disease progression. If imaging is done and they find that the kidney is smaller than the baseline, does that mean there's been some fibrosis of the kidney? Is that what
Yes. Yes, okay. Probably yes. So okay. as it's the chronicity, and that's why early intervention is important. Everything that we can do to slow down kidney disease progression. Because once the kidneys are smaller and shrunken and fibrotic, then though that is done, kidneys, the kidneys have, especially the podocytes, have limited, if any, capacity to regenerate. So they do have some capacity to fight off the injury. They have some capacity, some portion of the nephron at least, to regenerate. But once they're replaced by scar tissue, which is what I share, the small, shrunken fiber kidney, that scar tissue cannot be replaced. We can't get the nephrons back, at least as we speak of today. So yes, it does indicate chronicity of the condition.
Thank you. I'm going to get back to the chat in a minute, but this question came up several times in advance. What is the significance of a 24-hour urine capture versus just a one-time urine sample? What additional information does a 24-hour urine capture? And how often would you recommend that your patients have a 24-hour urine test in?
Great. So the 24-hour urine collection gives us what we call the timed collection. So there are two kinds of urine tests that we do. We do a timed collection. It could be 4 hours, it could be 12, it could be 24 hours. And we do a spot. And the spot meaning is you go in, you pee in the cup, and they check it. It's a spot at that given time. Now, the 24-hour urine collection has a lot of advantages. And one of the advantages is that we get the collection for the entire day. So there could be, I won't say minute to minute, but there could be fluctuations hour to hour in how much protein you're spilling, the creatinine, and so on and so forth. But the 24-hour urine collection will give the entire spectrum, right? It gives the whole area under the curve, or whatever you want to call that. So 24-hour urine collection has a lot of advantages. We check for protein, we check for creatinine, and all that stuff. But it has limitations.
And how often would you encourage us as patients to have a 24-hour urine?
Yeah. So, and that is based on the limitations. And one of the biggest limitation is the inconvenience it creates for the patient. You have to collect it, you have to store it. I mean, if you're working, you can't do that. So that's number one. A lot of times it's not even properly collected. A lot of patients under collect, over collect, and then you ask them to repeat it again. So we normally, we try to do it at baseline, when they come in, and then I just ordered a 24-hour urine collection in a patient today. And the reason why we indicated that was because there was something was not adding up. So when do we repeat that? Once again, a baseline is always good to have, but you don't need that. A lot of people don't order a baseline 24-hour urine collection, but it does add value. It does add some strength to our evaluation. And what we go for is what we call the spot, and that's listed over here. I'll go over this. The spot creatinine, and this will answer your question about how frequently. The spot protein creatinine is we check the urine for creatinine, and we check it for protein, and we take the ratio. And this is quote unquote reflective of 24-hour urine collection, this ratio. Not exactly, but it could be.
That's very helpful. There's a question here about with existing proteinuria in a stage 1 patient with a normal GFR, have you seen blood pressure medications help slow down the progression for a healthy patient with existing borderline low blood pressure?
So before I forget that, I just want to mention one more thing. If this protein is replaced by albumin, it's called the albumin creatinine ratio. It's exactly the same thing. We're just looking at a specific type of protein. And the reason why we prefer this over the 24-hour, the spot, is convenience for the patient. I mean, otherwise we would have been doing that every single time. So,
that makes sense.
Yeah. Going back to the question, you have to be very careful about when you have low blood pressure and protein, because you don't want the blood pressure to be too low either. Because low blood pressure can affect kidney function, and can cause what we call an acute kidney injury on top of that. So the short answer is that no, we don't know if patients are really that low, that what benefit they can derive. But you have to put things in perspective, because you do want to avoid too low of a blood pressure as well. And in that case, I would say tread very lightly or carefully on that.
Thank you. This is another question in the chat. If my nephrologist doesn't currently test for all important metrics, such as cystatin C, what's the best way to have this added to our labs?
So that's a very good question. Cystatin C is not mainstream yet. It's an up and coming test. UCLA has it on their labs. We do it ourselves. But we normally look at trends. Rather than absolute value of creatinine and GFR and stuff. But it might not be a bad idea to ask your lab, see if they do cystatin C, and if there's additional cost to that, because it might be more expensive. So if that's the case, then I think your nephrologist, you should talk to your nephrologist. Will this add any value to what's already happening? So once again, we don't want you to get stuck with a $1,000 bill. I don't think it's $1,000, but it could, it could be expensive. So the short answer is, first of all, ask if your lab is doing this, second, if it's an additional cost, and if there's an indication. Normally we add Statin C when there's a concern about, the creatinine not being accurately reflective of kidney function.
Thank you. That makes sense. It's another value that could bring context and information and trying to figure out a cause. Is that correct?
Yes. And also the kidney function. Statin C might be a better marker than creatinine, but it also has some of its own limitations too.
And this isn't about labs, but I do want to have you answer this question because I know this is one of your areas of expertise, and it is in the chat. An anonymous attendee asks, do you find that Alport patients are just as successful at transplant than anyone else?
Say that again.
Do you find that Alport patients are just as successful at transplant than any other kind of chronic kidney disease?
Yeah, I mean, so the question is it successful? Actually, in some cases, they might be even more successful depending upon what condition we have. But in general, yes, they are, because it's caused by a mutation, and the new kidney that you're putting in does not have that mutation. So yes, they'll be quite successful. I mean, there could be some of those cases which, outliers that there might be problems with, but overall, yes, they're quite successful.
Thank you, Dr. Rastogi. I know that doesn't have to do with labs, but
no,
I know this is an area of expertise.
It's an important thing, Lisa, but one thing that I want to say is that kidney transplants works very well, but it's still not your own kidney, right? It's still, and you will have to take medications. You have to do a lot of stuff. So the key goal is to preserve your kidney function for as long as you can, and hopefully new treatments will come out that actually, are disease specific. So I think I really want to make sure that we always keep that perspective in mind.
Thank you so much. I'm going to try to get to as many questions as I can as we're running short on time now. It says, as a patient, there are a lot of tests, and this is true. And sometimes it's hard to digest all of it, right? We've talked about a lot of things today. There's so much more time that we could spend. There's so many questions, but is there a single test as a patient that we should focus on? Would you say that's creatinine or EGFR, or is there a specific thing that we should really most watch the trends over time?
Yeah, so the two most basic tests that you should know is GFR and this protein creatinine or albumin creatinine ratio. Those are the two things you should always know. And then after that, it depends upon your kidney. I mean, are there potassium abnormalities? And we went over a bit of this. Potassium gets, this is important, total CO2, this is the acid load. And in patients with kidney disease, this number gets lower. So the total CO2 should be 22 or above. So after GFR and after protein in the urine, I will make sure the potassium and this total CO2 are actually quote unquote within normal limits. And then as your kidney disease advances, probably phosphorus is going to be a key player. So this will advance as we go along, but the two basic tests that you should know is EGFR and the amount of protein or albumin that you're spilling in your urine.
And is this where for one of those labs, when you were speaking about the CO2, is that where the bicarbonate would come in?
Yes. Yeah.
Okay.
That's where the bicarbonate comes in.
Okay.
And,
and in terms of actually additions like that, there were two questions. One is, can vitamin D supplements improve my vitamin D count? Is that helpful? And why does my doctor make me take magnesium supplements as a post-transplant patient?
So very good. So let's do the first one. The vitamin D supplements, your level should be at least between 30 to 50. So always check the vitamin D levels. So this is what we call the bone panel for kidney disease. You check the vitamin D levels, you check the calcium, and you check phosphorus, and these get altered. So we want the vitamin D levels, and to be more specific, it's 25 hydroxyvitamin D to be between 30 and 50. So that's what we focus on, and that's why your nephrologist or even your primary care physician might be ordering these labs. But this is a bone panel within the kidney disease. The other thing was a question about magnesium. Now, magnesium, magnesium is a very important mineral and element in our body, and if it's low, it can cause problems. And some of the medications that you're on for transplant can actually cause your magnesium to go low, and that's probably why they are putting you on magnesium.
That makes sense. Thank you so much. I want to make sure we're getting to all these questions. I think we have most. Can you elaborate on glucose concerns in those pre and post transplant? And should I be overly concerned if there's a history of diabetes in the family on top of the Alport syndrome?
So Lisa, can you repeat the first part? I apologize. I couldn't hear that.
Sure. Can you elaborate on glucose concerns in both pre and post transplant?
Yeah. So first of all, diabetes is the single most important cause of kidney disease in the U.S. And just because you have Alport does not mean that you cannot become diabetic. So now, if you have Alport and diabetes, then there's a concern that disease will progress even more rapidly. So controlling your diabetes is very, very critical. And that's why we check for glucose. Now, Alport syndrome by itself is probably not going to lead to diabetes, but at the same time that if you have it on addition to your Alport, it's going to cause the disease to progress. But post-transplant, once again, we spoke about magnesium. Post-transplant, you can get, because of the medications like steroids, your glucose can go up. So there are medications that you're being given that's why I'm saying transplant is not your own kidneys. You're given all these medications that can have side effects and adverse events. So you have to be careful about glucose. The other important point to keep it, and we check them regularly, especially on steroids, they are. And then if you have rejection, they can give you even higher doses of steroids. The other important point is if you have diabetes and kidney disease, as your kidney disease advances, your blood sugars get better. And it's not that your diabetes is getting better. The problem is insulin is cleared by the kidneys. And when they're cleared by the kidneys and the kidney disease advances, there's more insulin. So you get this false sense of security that my diabetes is getting better, but actually your kidney disease is getting worse. But what happens post-transplant? Well, guess what? Your kidney disease is gone now, most of it at least, so diabetes might just come back because of that. Because it's not that diabetes ever went away; it's just that your kidney disease was masking it. So that's the thing that I would recommend our Alport patients or any non-diabetic patients to keep in mind when they're thinking about glucose and its monitoring.
Alport syndrome is so complicated and there's such a variety of experiences,
Yes.
based on age, sex assigned at birth, genetic variant. We are all so different and so many experiences.
Yes.
So we appreciate, but it's so important that we all, at least we can have our individual labs and know how to evaluate them,
Yep.
how to ask questions, right? And what are the most important things to look at?
Being proactive.
We just have a few moments, so I thought I would just turn to you and just let us know if there's anything else you would want to leave us with. I will tell everyone that we are going to, this is recorded, so we will upload it to our YouTube channel on www.alportsyndrome.org for others and for those who couldn't join us today. We will also forward questions to you, some that were more of a personal nature, directly about a person's particular health. I will send those on to you and CC the person. But is there any thoughts that you'd like to leave us with today as you speak to us as patients, what we should be focused on to be proactive?
No, I think this is a great step towards being proactive and being your own advocate. Like I said, drugs and medications you should know on the back of your hand. And if you haven't seen that webinar that UCLA put together a few years ago, please do look at that. And then the second one is labs. We haven't done one on labs yet because the COVID hit. We were supposed to do a webinar on that, but once we have that up, I will let you know. But no, I think, Lisa, this has been great. It's been amazing working with you. If there's anything, I'm going to put my email there again. It's very simple, core kidney and at MedNet. And also, Lisa, we are doing those chat programs now every month, first of every month. So I do want to say Lisa always participates in that. So our next one is always first of the month, 5 to 6 p.m. Pacific Standard Time. And if you don't get the invite, please let Lisa or myself know. But the next one we are doing, which is very important, Lisa, and I wanted to bring this up, is how to stay healthy during the holidays. And this is both from mental health as well as from nutritional health. And both of them, and we'll have our psychologist, psychotherapist, Jim Cunningham, speak on staying mentally healthy during the holidays. And we'll have Rebecca Goodrich, and I think one of our colleagues, dietitians, might join as well. And they'll be answering how you can enjoy the holidays, but how can we make it, making sure that you stay healthy during the. So that will be my big message.
Thank you. When I send out the recording to everybody who registered for the event, whether they could join us or not, I will make sure that I send out the link for that as well. Yes, I have enjoyed. Thank you so much for joining you each month for those. Thank you so much for your time and your expertise and your dedication to patients and helping us be so proactive about our health and understanding our lab values. As a patient myself, I'm finding it really helpful to make sure that I stay on top of tracking trends for myself. For my son with Alport syndrome, it's really made a difference in terms of being able to ask questions and understand and point things out. I really appreciate your expertise and your time today, Dr. Rastogi, and for serving on our board, our medical advisory committee.
Yeah, one last thing that I want to mention is, we should do this a follow-up to this, knowing your labs. And if there are patients who want to share their labs after being de-identified, like we did today, we can go over some of those labs. So people can feel. So if somebody wants to, I'll be very happy to go over, just, actual labs from these were actual labs, by the way, but from other patients as well.
Well, thank you so much. We can work together to offer that, and appreciate your help so much. Thank you so much, everybody, for joining us today. We look forward to having you join us for additional webinars. Thank you, Dr. Rastogi.
Thank you.
Goodbye, everyone. Thank you.